All right, the first case that we're going to jump into today is a 90-year-old white male who's been followed at the University Eye Center for many, many years. His case is very significant for moderate normotensive glaucoma. He's currently being treated with latanoprost and timolol. What makes his case really interesting is that over the time that we've been following him, he's had recurrent Durant's hemorrhages in the inferior temporal part of his optic nerve, and we can see that on the image right here. Another thing that's very interesting about his history is that he has a history of chronic inflammatory demyelinating polyneuropathy. So he's one of my favorite patients to look at in Forum because there's just so much data that goes into taking care of his case. When I come into Forum, I always set up my settings, as we've already discussed, with the superior RNFL, the mean deviation inferior, and then opposing it, the inferior RNFL and this mean deviation superior, so that I'm seeing correlating structure and function together so that I can look and see where we have progression happening. When we come in and take care of our patients in Forum, I think it's really important to insert all of the events so that we really have a good sense of what's gone on with the patient, where we've made changes, where there's been something significant in the patient's history. So in this case, we have an event where we've added a drop, we added latanoprost. We added all of the different times that the patient has had Durant's hemorrhages so that we can look really closely for change over time with those. And then we can also see that we added an additional drop timolol along the way. So when we start to look at the case, we can also take into the picture our clinical exam findings. And so I've also included his IOP findings down in the corner. And we know that he's had these 3 Durant's hemorrhages over time. At one point, we decided that it made sense to actually add the timolol, and we can see that that was done here with this little yellow line, and we can see that the right eye pressure was a little bit elevated prior to that point in time. One of the things that I think is really important when we look at this case is actually to look with the different subset of the nerve fiber layer analysis. So typically when we get our OCT printout from the Cirrus, we are getting a T-SNP curve. And so when we have our T-SNP curve, we can see that we actually do have some progression. It's out kind of on the edge of the picture. But when we actually change over to the end-STIN curve, we can see that it's much closer to the area that's going to be affecting the patient's vision long-term. And so 10-2 visual fields are going to be really important. One of the other things that I think is really important when we're looking at this is that we've had these recurrent Durant's hemorrhages over time. We've had progression. We can see the change over time, but we don't see it very significantly. It's only popping up at the very, very last visit showing that there's significance there. And so we have progression, but the progression is in the green. And so that's really important for us to take a look at and keep in mind when we're going through the patient. So here we've got the thickness and sensitivity maps. I think that these are really, really important to look at when we're actually managing our patients. The first screen that will pop up is going to be the progression analysis. And when we just look at the progression analysis, sometimes you can forget how damaged the eye is and how much nerve fiber layer ganglion cell loss is there. But if we actually look at the thickness maps, we can pick up that we have this thinning over time in the inferior temporal area corresponding to the Durant's hemorrhages that we've seen. We have a picture of that Durant's hemorrhage back. And then you can see overall the ganglion cell analysis, we have that thinning in the macular vulnerability zone over time as well. So these are really important things to keep in mind when we're monitoring our patients and utilizing Forum to really get a good picture of what's gone on with our patients. I also find it really important to use the visual field browser when I'm looking at patients. When we go into the browser, it will show you the different visual fields over time, with the most current visual field being at the top. And we can see that we actually have some progression. We can see that we have this spot really close to the fovea that's being affected. And so it's, this is going to be another indicator that we really should grab a 10-2 on the patient. And with also when we're in Forum, we can utilize and we can add all of the additional information. And as we've already shown you, with the actual numbers, the values of the thickness. And so we can see over time with this patient, we've had significant thinning of the nerve fiber layer, or the ganglion cell, over time. And we've actually gotten almost to the floor. So it's really important that, this is definitely going to be a significant change for the patient over time.
With this case, I like to look at the pano map. And one of the reasons we need to look at the pano map, because it gives you a whole view of what's happening in the nerve fiber layer and the ganglion cell layer. As you could see, from baseline, there are some changes happening in the ganglion cell layer. You can see here, there's a nerve fiber layer defect that's occurring, and that's the baseline. If you follow it over time and you look at one time there was a advanced hemorrhage, you see there are more changes happening in the ganglion cell layer. And the defect in the nerve fiber layer is increasing, not only inferiorly where the advanced hemorrhage is happening, but even superiorly. And this is happening over time in the eye. And once again, a year later, post-advanced hemorrhage, you see deepening of the defect. So there's more thinning in the ganglion cell layer and the nerve fiber layer. And we do need to thank Dr. Hood, because he has attracted our attention to the ganglion cell layer and what's occurring to it, and the use of it in early and advanced glaucoma, and the need to use 10-2 on those patients. So if you look at the 10-2 that was done at the latest time the patient was seen, you see a defect near the center. And just a review to a lot of you know, the difference between points are in the 10-2 are 2 degrees, whereas in the 24-2 are 6 degrees. So you can miss some defect if you just depend on the 24-2. So in this, it highlights the need to do a 10-2 in those patients and to look at progression in the ganglion cell layer and maybe use the PanoMap. And this is the visual field defect representing the change. But if you look at the mirror image of that, you notice that it actually overlaps the deepened area of the defect in the ganglion cell layer. Our second case is a 70-year-old male with normal tension glaucoma sent from the primary ophthalmologist for a follow-up. The patient has a history of SLT. Ocular meds are Simbrinza and Vyzulta, non-responsive to Ropressa, unable to take any Diamox or any other medication. If you look at their pressure, his pressure mostly ranges in the mid-teens with some fluctuation in the IOP. If you look at the right eye, as mentioned before, I like to look at the visual index and the mean deviation for the visual field on top, and I like to look at the average nerve fiber layer thickness on the bottom and the profile, because it gives me a good overview. But there are other things that I look at, which we will be discussing more later. So if you look, there are in the progression map, it doesn't appear that there is any change occurring on this patient. The ganglion cell layer is stable, the nerve fiber layer is stable, and the visual field is stable. If you look at the deviation from the normal, which I think is very important to look at, you see that there are some changes. They're not progressing, but they're there. There might be some changes in the last OCT, that there's deepening in the nerve fiber layer inferiorly and in the ganglion cell layer. That tells me that I have to monitor this area in this patient for potentially future change. And if you look at the thickness and the sensitivity map, it appears very stable. Now, if you look at this patient's left eye, which is the eye of concern, you notice that there is slight change in the visual field index. The rate of progression is a year is there 1.7. And if you look at the mean deviation, it's not major, but there are slow changes there. If you look at the average nerve fiber layer thickness and the last examination, you see that it's turning to yellow. That means there is change. And if you look at the nerve fiber layer thickness, inferiorly, there's continuous change. But this tells you that you need to look at the progression more closely. If you notice, the thickness has been, although not significant, it's been changing over time. And it started in January 2019 inferiorly. It's confirmed in April 2019, and then January again, it's getting deeper. And in July, it became even more deep, and you're starting to see the ganglion cell layer changes. So the question is, should we be addressing changes earlier then what we usually do should be we be looking at the progression map, and when do we intervene in patients? Should we wait until we see the yellow, or should we intervene earlier? And if you look at the deviation from normal, you actually can see changes again in 2019, further changes, even before that, December 2018. So it's occurring prior to even looking at the average nerve fiber layer thickness. So that tells us that we need to monitor a lot of indices and looking at a lot of things when deciding when to treat and when to intervene. Now, the visual field is an issue in this patient. He doesn't do good visual fields, so that's why it's always an issue. Now, if you look at the thickness and sensitivity, you notice there's changes superiorly and inferiorly occurring over time, but they're subtle. So it's very important to look at the whole patient and looking at all the images, not only on the summary that's available on the glaucoma workplace.
One of the things that I think also what I really like to look at in this patient is because we have this very, very slow progression of the RNFL over time, I think it would be really interesting to look at the RNFL thickness profile in the deviation format on each individual encounter to see if we actually can pick up that change in a more visual way. Because as we said, this patient really, the visual fields are not going to be, he's just very unreliable with them. And so we have to take that out of our, part of our examination and look a little bit differently with all of the different pieces of the puzzle that we have.